So I think we're right on 6:30, so we might get started. I'm sure it's been a busy day for you all. Thank you so much for joining us for the National Immunisation Program Update 2022. My name is Bianca. I'm the Director of Primary Healthcare Improvement at Northwestern Melbourne Primary Health Network, but we're presenting this session in conjunction with PHN colleagues from Eastern Melbourne Primary Health Network and West Vic Primary Health Network. So welcome to participants from those PHN regions as well. Thank you so much for joining us on what I'm sure is an incredibly busy time in general practice. And I feel like we've said that for the start of our last sort of sessions over the last couple of years, but really appreciate you taking the time to join us tonight for what will be a really informative session. So before we start officially, on behalf of Northwestern Melbourne PHN and the other two PHNs, we would just like to acknowledge the traditional custodians of the land and acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today, and that's certainly for Northwest Melbourne Primary Health Network. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging, and of course honour the traditional custodians from wherever you're dialing in from. Just a little bit of housekeeping. So we're working on Zoom webinar tonight, so everyone is automatically muted. We'll be asking sort of questions through the question and answer box. So please type your questions and we'll be answering them at the end of the presentation. The questions will be anonymous to protect your privacy. This session is being recorded and we just need you to please ensure that your name is in the Zoom webinar is correct if there's any CPD points that we need to allocate for you. So tonight we're joined and we have had Peter give presentations previously, so really excited that we could have Dr. Peter Eizenberg back again to present the immunisation update. Peter is the GP Director of Doctors in Ivanhoe, a current member of various immunisation groups, the Vacs Safety Advisory Committee, Influenza Specialist Group and Immunisation Coalition, and as a former member of a number of, again, national immunisation groups. Peter Eizenberg also contributed to the Australian Technical Advisory Group on Immunisation e-Handbook Working Group and the Australian Primary Healthcare Research Institute at Australian National University. So a very truncated introduction for what would have taken us a little while to get through. So Peter, I can see that you've turned on your video. Welcome to you, and I'll stop sharing my screen and we will hand over to you.
Thanks, Bianca, and welcome to everybody. And it's very nice to be here tonight to talk to you all about so many issues in immunisation that we need to cover. And so you're able to see my slides there. I just wonder if we can resume the slideshow as we had it before, Bianca.
Yep. So just need to press the share screen.
Excellent.
Peter at the bottom. Yep, and that should work for you.
Perfect. How's that looking at your end?
Not seeing it yet. Oh, here we go. No, it's coming now. Yeah, got it now. Thank you.
We're all live. That's great. And welcome again, everybody. So now we've got quite a lot to cover tonight with one of our usual updates. And so there's going to be quite a lot of information, and just not getting the slides advancing. There we go. So the customary declaration of potential conflict of interest are displayed on the screen. And just to confirm that whilst I'm a member of a number of relevant advisory groups, and I'm also involved in research for some of the products that are covered during the evening, I have no ownership or shares in any vaccine or pharmaceutical company. And the views that I express in this talk is entirely mine. So I won't bore you with the details of all of the representative positions I've had for general practice, but I will bore you about these topics for the next 2 hours. Don't fret too much in that all the references and resources will be provided, and they are the customary ones for immunisation, to refer to TGA for relevant product information, consumer medical information for COVID and other licensed vaccines, Atari for the excellent guides they provide, which are updated frequently, as you know, the Australian Government Department of Health also providing lots of guidelines and frequently updated, and naturally the COVID-19 vaccination training modules that all practices that are involved in handling or administering COVID vaccines are required to be up to date with, and all of their changes. The NCIRS, that's the National Centre for Immunisation Research and Surveillance, also produces terrific clinical guides in lots of topics beyond our scope for tonight as well. And Vac Safety is the National Vaccine Safety Surveillance Program that will be looking at how they can be of use to you and vice versa for monitoring vaccine safety. The Immunisation Coalition is a national body of group of all providers, experts, and in research and in industry and government who help to work out, help to keep up to date and to pool knowledge and experience, and also to help providers such as you and me. And of course, the Victorian Department of Health and Human Services and the Melbourne Vaccination Education Centre, which is a collaboration of the two together with the Children's and Monash Hospitals and Safe Vac. They are they are enormously important at setting guidelines that are Victorian specific, and our definitive reference for everything is the Australian Immunisation Handbook. Those resources that I'm specifically going to talk to tonight are also listed here and will be available to you after the session. So if you want to save yourself 2 hours, you could just flick off now and find something better to do. Or if you'd like to stick with us and step through these guidelines to see how they can be of most value to you. Of course, what we present is up to date for as close as we can be, but this is last week's mail that's arrived on my desk. Yours is probably looking similar. So we try to keep up to date as much as we can with the moving target. Most important reading material is how to read a scientific research paper, which I think a lot of people could well do to read. In the media and in the public forum and social media, there's a lot of people who really should be reading that before they read a whole lot of other stuff. And we'll look at a couple of issues where that's important. So let's first dive straight into COVID-19 vaccination update. And to understand the vaccination side, we really have to understand what the disease epidemiology and what developments are. So the references, of course, the Department of Health COVID-19 vaccination page, and the references there are numerous and very helpful. And especially that vaccination training program, which in itself is beautifully produced and comprehensive, well displayed and consistent, and a great learning tool and a reference tool to go back to if you're looking for information that you can't find. We're also going to take a deeper dive into one of the latest tools that's available and replaced previous versions as more vaccines have been added to it. So now that Novavax is added to the suite, this chart has been updated. And it's actually quite hard to find. And so I'm going to mention that if you just put in COVID-19 vaccines, you'll get the older charts. You have to actually add A3 poster to get the correct slide without having to spend a lot of time searching for it. We'll come back to that and look in detail. We're also going to have a close look at the weekly Melbourne Uni collaboration of COVID-19 vaccine updates of all the data around the world to try and understand how the experts come up with their decisions and try to find some detailed information that you want to maybe have a look back to, and we'll look at those in a few moments too. And I want to also focus on the safety aspect, that is what the latest safety data is saying specifically for COVID-19, and we'll expand that later in the talk to look at other vaccine preventable diseases that we deal with to see how these tools can be of great use to us. There are a couple of expansions to the decision aids that have been released before, and the recent addition of the 5 to 15-year-old decision aid for parents to help work through the tricky conundrums and difficulties in making decisions about vaccinating their children. Always, health pathways is a terrific tool to all of us in clinical management of lots of conditions, particularly COVID-19. And so the Melbourne Health Pathways actually has different different areas for minor differences in, for example, criteria for eligibility for programs and what things are run in various areas within Melbourne's areas. And so having this as a reference for you, for immunisation in general and COVID in particular, is an excellent tool. If you're not yet using health pathways as a daily tool, you really want to go into it and have a look how useful it can be for you. And health pathways exists also for our friends and colleagues in Western Victoria. Welcome tonight to this group, and the health pathways that are applicable to your area are displayed via your access point. So to start COVID-19 understanding of and help inform our vaccination program, I find there's nothing better than to get a really great view of the infographic. They actually update this just about every day, and it's a national picture, and each individual states have their local versions as well. And it gives you a figure of how our total cases are going, how many deaths, sadly, we've had, to 5,700 to date. And it gives a snapshot of the daily numbers of reported cases, and waves 1 and 2 hardly visible on the scale of what we're now looking at. This was our Christmas, New Year peak, and here we have our curve to date. This is also very handy perspective to get that difference between the age distribution of cases showing peak in early adult versus the relative disproportionate burden of deaths in the older age groups. And we're going to look a little bit more detail at that. The case numbers in total cumulative is here in yellow, and this is the daily spread. There you can see just that hint of the first wave there. That blue smudge is the second wave. And this just gives the perspective of how many cases we have now. Not unexpected. This is living with the virus, of seeing huge numbers of cases, hopefully in vaccinated people, which we didn't really have back here. And if cases had have run wild without proper, without strategies to reduce the spread, all of those, nuisance though they are, help delay this this surge for a time when we're as well protected as we can be, and we're in a very good position, but not perfect, and there's more we can do. So we're going to have a look at that. That chart that I just mentioned is expanded here, and the ABC actually present that in a slightly different way that I think help accentuates the disproportion of age case burden versus age death burden, and you can see the relative disproportion of the elderly. And these are people who didn't need to die yet. These are confirmed COVID-related deaths rather than incidental deaths. That is, people who somebody gets hit by a bus and they happen to have COVID, didn't die from COVID, but people who have a COVID-compatible clinical illness and died, they appear in these charts. And these show the relative proportion. The other, I think, useful chart to have a look at is where we've seen cases. Here are the daily tests, and we can see the numbers of tests, and these represent the PCR tests that have been done. And these PCR tests have fallen off as rapid antigen tests have replaced them. If we look at the cases versus the tests, we get another picture. This section here is simply the different time scale representing this point here and this point here, and it's spread out, and it's showing the cases matching very similar to the PCR positive tests, and some of these are made up of a rapid antigen test as well. So these are total PCR tests, not just positive, and these are confirmed cases, not just PCR tests. Keeping an eye on the hospitalizations, there's our first and second waves showing up on this scale, and in crimson there's ICU admissions and ventilators in blue, and here is the death rates matching that, but at a slightly smaller scale. So let's now look at the vaccine rollout of the Australian government figures, and we see this absolutely impressive, whopping nearly 56 million doses given in Australia to date of COVID vaccines. That really is staggering on any scale. It's showing that at least one dose is by over 95% of the people over the age of 16, and touching 95% of people who are fully vaccinated. So very small lag between the two in the overall scale of things. And people who've received booster doses, also very impressive number. Here are the booster doses, and it shows that we're up to, for eligible people, 66%. Indigenous Australians, almost 50% have received booster vaccinations. So we have still a long way to go to get them up to the same level of protection we are. The other detail is buried in fine print of looking at the age breakdown of those under 5, showing only 50% vaccinated, and not even 20% yet second doses. So a lot of work still needed there, and 12 to 15 showing a midway point. But our over 50s, over 99% vaccination rate. So a really impressive and happy position to be in compared to where we were a year and a half ago. The charts also show a proportion of where the different doses of, this was in blue, the AstraZeneca doses, which featured earlier on in their important role then, and as Pfizer doses became more available, they are predominant, including first, second and third doses here. And we're now seeing some Moderna appearing on the chart, but we've not quite got enough of the Novavax to feature yet, but as the time goes on, we'll see more yellow appear there. Indigenous figures we looked at before, and we are happy to say that over 16, nearly 84% of Indigenous adolescent adults over 16 are vaccinated, and double vaccinated, nearly 80%. These need a lot more work to get up to closing that gap between Indigenous and non-Indigenous Australians. Now, the ABC represent the data slightly differently from how the Australian government does. The Australian government figures that we just looked at are very much focused on eligible population, the percentage of eligible population who have been vaccinated. But there's a bigger picture, and that is all Australians, including those who are too young to be vaccinated. And so they are not too young to get COVID and to transmit COVID and contribute to other more vulnerable people getting, particularly age-related, getting severe illness. So we still need to keep an eye on the fact that we've got to try and get our figures up of all groups. And we haven't yet reached 50% of total population of Australia as being vaccinated. And the projection, the age claim, is that we can expect 90% of our total population, whether eligible for vaccination or not, will be double vaccinated not until mid-December 2022. So that's just a little bit of sobering thought to the impressive pictures we've seen. The age is also displayed, I think, very well here, how the different doses have rolled out on a daily basis, a 7-day average in the heavy line here, and this light blue shading is the third doses. And here is the indigenous percentages of vaccination rate showing up for people aged 16 and over. And just to get to the end of these, we glean a little bit of perspective of comparing the over 16s, the over 12s, and the all ages. And we see here that the percentage coverage rate is important to understand what group are we talking about, because there are differences. It's also important to keep the perspective of where's the rest of the world at. And you can see that we are way above the majority of the world, and it's a bit of a worry to consider that, that worldwide there is still so much exposure, and particularly when we look at vulnerable populations in Africa that are barely 15% fully vaccinated, or at least double vaccinated. Fully vaccinated to protect against Omicron really need that third dose. So I want us just to dive into this latest chart, which I think is such a valuable tool to have on your desks. Essential, I'd say, if you're a practice that are delivering more than one brand of vaccine, but even if you are just delivering one brand of vaccine, this chart has been improved and contains so much of the important information to help avoid confusion on any particular day. Remember, if you're Googling it, you must put in COVID vaccines in Australia A3 poster to find the latest version. So how it's divided up, just go backwards, how it's divided up on the front, it's looking at the primary courses, broken down by all the different vaccines that are available for COVID-19 vaccination. And on the flip side are the booster doses. And what's displayed down the side is all the useful practical information when you're giving vaccine. So to look at the top half of the page first, you've got the vaccine type along the brand name and the approved age for each of the vaccines. So there's no confusion when you're in a busy session and tripping over yourself to try and keep on time and accurate and up to date and satisfy everybody's needs. The cap colour, of course, displayed, and the dose volume as a reminder, doses per vial and the dilution required, as well as the recommended dose intervals and the approved primary course dose intervals. And the third dose where it's licensed and indicated. And there's a couple of asterisks that you'll see when you get to the bottom of the page. Those asterisks help describe some of the most important and common variations that we might see in doses for different age groups and different options for dose intervals. And this lower part of the body of that primary course front page looks at the different storage temperatures and recommended periods for drawing up and having those vaccines out of the fridge and the storage times for them. And this chart's been updated with the very recent changes that were introduced in the last week, I think, that affected the Moderna vaccine for the period of duration that it can remain frozen for. On the flip side is the booster information and which brands are licensed and what circumstances, and the dilution and recommended dose intervals, as well as the storage variations where they occur. So well worth having that chart at your fingertips. And I reckon half the questions that come into the chat group tonight will be answered by a glance at those charts. So now I just want to focus on another very technical but a very valuable tool to have available to you, and that is the weekly vaccine updates by University of Melbourne, and these are a collaboration of experts there who help prepare this information. And I'll just show you what they look like. We're not going to delve into great detail other than to show you where to look. So what I say tonight is going to be hard to retain in a few weeks' time when a question might arise, but you'll know where to find it. The important thing is they summarise the vaccine efficacy data as it evolves from all over the world on efficacy and effectiveness, and vaccine specifications, the development pipeline, what's coming, and a timeline for the various COVID vaccines in their phases of development. It emphasises the difference between vaccine efficacy and vaccine effectiveness, and it's important to understand this important distinction. Both are valuable but different perspectives in understanding vaccine performance. The efficacy refers to the performance of a vaccine in controlled clinical trials, and those are situations that are very well defined with criteria and conditions and circumstances that may vary across different studies and trials that are published. The vaccine effectiveness is how the performance of the vaccine is in a population under real-world conditions, and both provide critical levels of importance in understanding vaccines and understanding the difference of them so that we don't misinterpret information as it becomes available. So efficacy of controlled clinical trials are to help try and define the circumstances and the qualifications. But for example, the very limited studies will be directed to include pregnant women, for example, or immunocompromised people unless the study is specific for it. It will keep people out of studies who are at severe ends of various disease stages. So the efficacy usually will have conditions that will define very well the performance of a vaccine, but with certain limitations. The effectiveness is when you take that vaccine and release it in the real world, you get much greater numbers of people. You have less control over who gets vaccine, and many people who would be excluded from the study become included in the data, and it's important to understand that as the maturity of programs get into the millions, tens of millions, billions, and tens of billions of doses that are given. So to give you an idea of the scope of these weekly reports, these are all the topics that are covered each week, including those listed in the appendix. And this gives a very comprehensive and a timely update on the vaccines. So just to have a glance at some of these, the chart on vaccine specifications, similar to what we looked at on the vaccines slide just a few moments ago of what's available in Australia. These list all the vaccines available in the developed world and the different characteristics and properties, and that's handy to compare to if you hear about a vaccine or someone's had one overseas and we're not familiar with it here, you can look at that. And then there is a presentation on this chart looking at the vaccine efficacy against the different brand vaccines and looking at efficacy broken down in terms of symptomatic infection, moderate, severe illness, severe illness, and hospitalizations and death. And they all provide important information, and the different summary of the different studies is represented here to the extent that they can be. And the vaccine effectiveness summary at a glance pulls out other properties to help try and give idea of how the different vaccines are working for the different purposes we expect them to work for. So death and hospitalization, prevention of severe disease is the goal of the vaccines, and getting infected with mild symptoms or asymptomatic infection still needs to be taken into account. But very many people mix vaccine effectiveness and figures across these different parameters, and that really has to be cautioned against. These charts also dissect out what is known and published about vaccine efficacy and effectiveness against Omicron. also looking at effectiveness against Omicron for different combinations of mixtures of vaccine doses. So where they are homologous vaccine doses or heterologous or variations of them, it can be displayed for the purpose of understanding minor differences between different combinations. Also, a focus on these charts reporting on the effectiveness and efficacy for high-risk groups, and looking at the publications on those with diabetes, obesity, at risk for severe COVID-19, and elderly people across the different vaccine brands. Also children, so the data for the growing amount of data for vaccinating children is also displayed in these charts, as well as the effectiveness against asymptomatic infection, which is important to know as well when we understand how the vaccines are doing. And not just asymptomatic, but also transmission. What are the properties of the vaccines, the various vaccines against reducing transmission, and the variants as the data evolves, comparing the earlier forms of the strains that were circulating, the later developments of those, and into the Omicron as well. Here is the data on immunogenicity of boosters against Delta, and the information is growing. Just to caution the importance that if we're trying to examine two organisms or two studies that appear similar, unless those studies are head-to-head, the meaningfulness is limited, and we really have to caution people who leap in without understanding or potentially mixing messages, and we've seen a lot of damage in social media about that. To conclude this update section on COVID-19, I do want to focus on the vaccine safety, what's available, and this can be at your fingertips, just like that other section. And this is Vac Safety, which is a collaboration also of National Centre for Immunisation Research and Surveillance, for whom that is the umbrella for Vac Safety. And Vac Safety has most of its data from GP practice, Smart Vacs program, and you will hear more about that in time. And if you have opportunity to participate, it's a mutual benefit. So let's have a look at what sort of data, particularly first in COVID-19, and later we'll look at more. So the data is very robust. We have over 6 million safety surveys that have replied to the Vac Safety data. So that's pretty close to a little over even 10% of the total number of doses given in Australia to date are represented in the safety data that people have had vaccine and responded to an SMS at 3 time points, days 3, 8, and 42, after having their COVID vaccine for each vaccine dose given, and that reports this level of safety data that you see. What I'm going to show you is just a snippet of it, because you can have it broken down by all the different vaccines. And later we'll look at flu and the other National Immunisation Program scheduled vaccines, and it displays those people who reported at least one event and the proportion of people who had severe enough to have to get medical advice. And these are displayed. You can break it down by all participants, child only, people affected by cancer and transplant recipients, by indigeneity, adolescent and pregnant participants. And when you click on one of those, for this example, we're looking at the Pfizer adult formulation, and we see a display of pie charts. Firstly, the dose number 1, 2, or 3 represented in number here, and at least one adverse event after the first dose, 37% of people reported having something adverse, and dose 2, higher proportion, similar to dose 3. And the chart goes on. I'm not sure how clearly you can see that, but it's a breakdown of the type of reaction, whether it's local or systemic reaction, and the proportion after, whether it's first, second, or third dose. And for each of the Pfizer for adults, as we've selected. And it also shows the proportion of people as a percentage of those after first, second, or third dose who had a severe enough event to need medical attention. And you can see from the very low proportion of people who needed medical attention that most of these were mild and indeed short-lived, of just a few days. That doesn't represent the severe reactions that are seen rarely, but are important as well. But in terms of expectation when you're consenting a patient to have a vaccine, this is enormously helpful. This lower end shows those who reported having to miss work, study, or they're unable to do their routine duties because of the severity of the reaction. And these are the respondent demographics to show where those results came from. So that's an enormous resource. You can use that when you're consenting patients. You can update it weekly, and you can select a high level of detail or an overview as you wish. So here's the next tool that I think is really helpful, and that's a decision aid. Should I get the COVID vaccine for my child? And this is an NCIRS recent development for this age, and it builds on a couple of the older age groups, and it steps you through a number of different process in this to end up with some form of an informed decision to be able to tick the box of whether the child does go ahead for vaccine or not. On the way, as you go through these steps, step 1 is some information about the disease and the vaccines. And step 2 expands, and again, you can choose which age group you want, and it displays the health risks that apply to that age of interest that you've selected. And it will display the risk of getting a condition of comparing the virus causing infection versus the vaccine causing adverse reaction. And this display is much more personalized and gives a percentage that may be of help to people. A second tool, different from the NCIRS tool, is the Immunization Coalition Coracal tool, COVID risk calculator. And it displays in a different way the same sort of information to break down perspective of disease versus vaccine reaction. And you can again choose different doses, different circumstances, and it'll display in a didactic way this spread, much like a heart health display, of seeing a perspective rated age versus numbers of doses of which vaccines and combinations. It also displays a less of a chart, but more of that table that we saw a few moments ago for that other tool of NCIRS, that's more personalized to your experience and if you put in your age and what your medical conditions are and so on, and what does the chart look like of comparing disease to which dose of which vaccine. Also, very helpful tool in informing patients. Finally, just to remind you that the Atari technical updates are critical to keep reviewing and having a system in your practice that you can store and retrieve. So the latest charts in February, the recommendations on the use of or other guidelines, not charts, of the third primary dose of COVID-19 vaccines who are in people who are severely immunocompromised. And this has gone through a few iterations over the last 3 to 6 months, and it's now including the third primary dose of Novavax vaccines in there, the expansion to include immunocompromised children with severe immunocompromised condition. And I must emphasize the word severely there is important, and it's distinctive from immunocompromised in terms of other vaccines like flu and pneumococcal that we look at. This is special category for extra dose for a third primary dose, and it defines who and what. And you do need to refer to the box on the inside of that guideline to have a look at the definition of exactly who is considered severely immunocompromised as opposed to less severely immunocompromised, and for whom a third dose may not be indicated. Then there was the update regarding people aged 16 and older who've received the third dose primary course are now recommended to having a fourth dose 3 months or more after their third, and the information on Novavax being included, and those people 6 to 11 years able to receive Moderna vaccine. The next update was around the Atari expanded guidance on acute major medical conditions that warrant temporary medical exemption. And so it defines who is considered recommended, who has an acute major condition, medical condition that warrants medical exemption, and the parameters for it, including the reduction from 6 months to 4 months for that purpose. The use of booster doses was also expanded to include Novavax vaccine for people aged 18 and over, and the recommendation that AstraZeneca vaccine is not a preferred booster dose, preferred vaccine for a booster dose, unless they have contraindication to having an mRNA vaccine, and prefer that to a Novavax vaccine, and updated evidence of the vaccine effectiveness of booster doses against Omicron variant is included in that update. Almost every week, certainly every week or two, the primary care vaccine rollout provider bulletin is released, which gives a important guide to all the key messages and instructions for managing the program in your practice, and of course the fairly regular updates to the module training for vaccine people handling vaccine for COVID-19. So I think we've had COVID-19 vaccine up to the gills. Let's now get to flu vaccine program.
Peter, before you move on, we've just had one question about COVID that's come through in the chat. Sorry, now I can't find it. Is a client's refusal to take other boosters on offer reason enough to administer Novavax as a booster?
So the answer is yes, and it's a very good and a valid question, and that is dealt with in that last guide that I just showed. So the Atari guide does give instruction and some expanded advice about how to apply that. So the short answer, yes.
Thanks.
So let's now look at the flu program. So we've had very weird flu years. We've had extraordinary, unprecedented since the beginning of monitoring of these programs decades ago, and we've had really strange performance with the absence of flu as any significance for 2 years. Never had that, and we've never had it as low as either of those years in the past. So you'll remember in 2017 and 2019 were our peak years, and each one, I remind you, were preceded by a very low year. This was 2018 in between the two, and prior to 2017, not shown on this chart, but was also low. So we've seen this phenomenon that scares us, and that is that after a low flu year, there's usually huge surges the following year because natural immunity is absent in the community. We've now had 2 years with virtually nothing. Last year, almost literally nothing. And so the fear is that we may get a surge. Northern Hemisphere has had a significant surge, not as bad as it could have been, but the role of vaccination this year is all the more critical so that we don't have a twindemic, and a twindemic of pandemic of COVID together with surges of flu virus in the community. And if we don't have a diligent flu vaccination program this year, we may regret it later. So just to have a look at these data, we thank Professor Ian Barr, who's the Deputy Director of the WHO Collaborating Centre, and he presents these slides each year updated, and they're extremely informative and helpful. So just looking at the 2021 season compared to the earlier seasons of influenza-like illness, so that includes true flu and it includes other viruses like flu, and you can see that in 2021, all influenza-like illnesses were very, very low because of all of our distancing and masking and curfews and things that contributed to us reducing the risk of spreading all respiratory viruses to some extent and flu to a very major extent. But just to have a look at 2021 figure almost doesn't rate the scale we're talking about here. You've got to magnify it up by 1,000-fold to be able to see anything at all showing here, 15 compared to 15,000 on the scale of previous years. So we're looking at a complete low figure. For what it's worth, it's not that meaningful, but for what it's worth, the spread of types of flu A in red, orange, and yellow are the A strains, the green are B, but we're talking about hundreds of cases, not hundreds of thousands of cases. So absurd it was that at one point last year, Darwin was the flu hotspot because it had 56 cases, and it just showed you, and they were all from the Howard Springs quarantine facility. So that just shows you how absurd a year. And the trend, if we look at from 2019 to last year, the genetic diversity of the different strains and substrains that normally proliferate in the group we call H3N2, or the group that come under H1N1. A few years ago, there was diversity in those strains. It wasn't just one strain. There were lots of subgroups, less so for the B strain. But have a look at what it has evolved to with such small numbers of flu. The diversity is also reduced, and we're not sure what the impact of that will be once flu starts circulating again. There's the hope that Yamagata lineage of the B has actually completely gone. Whether that's forever or just 2021, we're yet to see. And that is the comparative chart year by year on the number of case notifications. Look, over 300,000 in 2019, dropping dramatically in 2020, and we're looking at just a few hundreds for the whole of 2021 with 0 deaths, and the case fatality rate obviously distorted in that way. So we're very much scared of what will happen this year if we're not protected enough. It's also important to see that not all respiratory illnesses behave the same as flu. So if we compare, a bit of a busy chart, but we're looking in this top section of flu A and B, and we can see that it fizzed and disappeared altogether for the last over the last 2 years, but not so with adenovirus, in red being 2021, parainfluenza, respiratory syncytial virus, which even made an unprecedented peak in 2020, late 2020, and quite a surge in 2021, rhinovirus, human metapneumovirus, and enteroviruses as well, the red being last year. So we'll talk a little bit about RSV because there's some exciting news coming for that. But the interesting thing is that not all respiratory viruses have gone the way of flu, and so to summarize, 2021, it was a non-influenza season. as an understatement, and the characteristics were quite extraordinary of seeing no deaths in 2021 and only 37 in 2020. The air data shows a bit of a worry because flu was low in number last year and people were isolating and doing all the rest. Complacency happened with a lot of vaccination, and so we have low vaccine uptake in the last year, and the air data shows huge reductions in the percentage of vaccinations. Still high in the over 65s, but disappointingly low, and with low transmission of flu in the community, that spells for a weakened immunity if we don't get boosted with vaccine this year. The vaccine strains that are included in the vaccines this year are demonstrated here. The red one showing new strains or variations of the genetic composition compared to previous strains. The original pandemic strain is pretty well unchanged. It has been since 2009, but the H3N2 has changed significantly, as has the B Victoria lineage. There is in the quadrivalent vaccine the Yamagata lineage, which is similar to what we've had before, and we'll really watch what happens this year. It's important to understand that we have, in addition to the traditional egg-based vaccines, we have cell-based vaccines, and we're going to talk about that in a moment too. But the egg-based vaccines are quadrivalent. All strains available this year are quadrivalent, and there's the adjuvanted quadrivalent vaccine for the over 65. And we do have this year also a high-dose quadrivalent that was available a few years ago, was on the program, and 2 years ago was swapped for the Fluad Quad. So we're going to talk about flu zone as well, because it is available this year. And the cell-based flu vaccine, Cell Vacs, which premiered last year for the first time, and this year it will be available again. Back at the beginning of this year, it was licensed like last year over 9, and just a month ago, 2 months ago actually, it's been lowered to 2 years. So it's licensed to use from 2 years, and we've got to understand what role that has, and we'll talk about that. In the future, we're going to be hoping for live attenuated influenza vaccine. That's a very prime component of the UK vaccination program for the last more than 5 years now. And we're also looking in the future to recombinant protein hemagglutinin vaccines and mRNA flu vaccines coming. But let's have a look for the first at the safety profile, courtesy of Rsv Safety, looking at the vaccine data that we introduced a bit with COVID, and we'll now look at it for flu perspective. So here we have the 2020 summary report showing nearly 300,000 people responding to text messages on following day 3 of after their flu vaccine, showing that 94% of people had no adverse reaction whatsoever, leaving 6% of people who had, and only 0.3% of people needing medical attention for it. The range of commonly reported adverse events are listed here, and the proportion of people who had them, and all of these lasted just a few days. So this is really robust data to help show the safety of flu vaccines and the true impact in the Australian picture of actual people reporting their level of flu vaccination rate. And this is much more live, current, and relevant to help inform people about safety of flu vaccines. The report for last year sampled this number of people with a similar proportion showing, and you can break down these charts according to age, 6 months to 5 years, 18 to 65, pregnant people, pregnant women, 5 to 18 years, and age 65 and over, and you get similar pie charts to what we saw before. let's step through for 5 minutes here the actual statement for clinical advice for flu vaccination in Australia for this year. This came out 2 weeks ago. If you haven't received it, Google it, print it, and study it, because this is what we're all rolling up our sleeves for. We got our delivery of some of flu vaccines already, and we are starting program in our practice, but not the funded vaccines until they arrive. So just the overview of the key points for 2022, and it's important we understand this very fluently. So remember that it is the most important measure for preventing severe flu illness and its complications for anybody aged 6 months of age or over. All vaccinations since, I think, March last year, all vaccinations, particularly National Immunisation Program vaccines and all flu vaccines given in Australia, must be recorded on the National Register, the Australian Immunisation Register. Because of that reduced circulation of flu we talked about before and lower levels of coverage last year and borders reopening, it is feared that we may get a resurgence of flu in 2022. The important point that all COVID vaccines can now be co-administered, even given on the same day with a flu vaccine, if indicated. For adults aged over 65, Fluad Quad is the adjuvanted influenza vaccine that is preferentially recommended over standard influenza vaccines. And that's the one that's funded this year on the National Immunisation Program for everybody over 65 and over. There's no preference for use, though, on an individual between Fluad Quad or Fluzone high dose in that age group should they decide to have one or the other. There is only a cost difference. The Fluzone high dose quadrivalent is literally 4 times the dose of standard flu vaccine for each antigen of the 4 antigens in the quadrivalent vaccine. Fluad Quad is the same as the standard dose, but it's adjuvanted with an inert protein that helps stimulate the immune system to respond to the flu antigen at the dose that's in it. And they're both considered to give probably 20 to 25% additional effectiveness in people aged 65 and over. Either, rather, not both. Only give one or the other, please. If a person had a 2021 flu vaccine in late 2021 for whatever reason, including pregnancy, they're still recommended to get a 2022 formulation when it becomes available. We'll talk about timing in a moment. Here are the virus strains that are in the egg-based traditional vaccines that are funded and those that are not funded if a person's not eligible. And the cell-based vaccines have slight variation just because of their technical components. Here is the really important chart that should be on the fridge and on our desks when we're running programs so that we make sure that we grab the right flu vaccine off the shelf for the clinical indication in front of us. So we've got here the chart breaking down the different age bands for the licensed and the recommended funded vaccines for each of the 8 available licensed flu vaccines in Australia this year. In unshaded here are the funded groups for the funded vaccines for those age groups, and there are some asterisks to indicate where specific funding vaccine brand for Indigenous, for pregnant, and for people with certain medical conditions. So we're going to have a little look at the flu Cell Vac Squad and the Fluzone, but this chart is what we bear in mind as to which vaccine is licensed and age appropriate. So a couple of highlights for that is that Influvac Tetra is the quadrivalent vaccine previously registered in children from 3 years of age. It's now down to 6 months of age. That is, can be given from 6 months of age. The flu Cell Vac Squad that was previously registered from 9 years, as I mentioned before, now from 2 years of age. And there are 2 higher immunogenicity vaccines available for older people. That's the Fluad Quad and the Fluzone high dose. The Fluad Quad is only for people aged 65 and over. The Fluzone high dose is available for people 60 years and over, I think for the first time licensed for that purpose. So there is a important difference there, and we'll tease that out as to how that impacts our delivery of vaccine. The COVID-19 vaccines can be administered on the same day as flu vaccine, and there's additional information about co-administration with Novavax in the Atari statement on Novavax. The safety of concomitant administration of flu vaccine, Fluad Quad and Shingrix has not been studied, whilst acceptable to co-administer them on the same day, but given the lack of data, it may be preferred to separate by a few days. So the timing issue is really important as well. Because of the reduced circulation of flu, the resurgence is expected, and that people who are planning international travel should ensure they have a 2022 flu vaccine before departure where they can, or soon after arrival wherever they are, if they need, particularly if they're staying any period of time. So our aim is to vaccinate annually before the onset of each flu season, and the period of peak flu circulation typically is June to September. Not sure that 2022 will be typical in many ways, but that's our typical experience. But flu epidemiology this year may be way out. So because it's unpredicted, and the experience in the Northern Hemisphere has seen surges in flu and coexisting with COVID-19, and bearing in mind that protection is generally expected to last throughout the year, particularly for immunocompetent people, but the highest level of protection occurs in the first 3 to 4 months after vaccination. So the issue is more in terms of picking when to give the vaccine. I think the general principle is to give it when it's as soon as it's available to those people who want to have protection. And I think we're going to be having vaccine available in April, a little bit already in March, but timing I think is less relevant given the need to get best protection as early as possible. Vaccination should continue to be offered as long as viruses are circulating. And if a person had, we mentioned this, to receive a second formulation, this is relevant particularly in pregnancy, where a person might have had a late 2021 flu vaccine and now need another one in 2022. So for pregnant women does need special mention because of the extreme higher risk to mother and baby from flu infection during pregnancy, that it can be given safely at any time in the pregnancy, any stage, but and in every pregnancy, even if they are pregnant 2 years in a row. Flu vaccine can be safely given at the same time as pertussis if they're indicated, as they are during pregnancy as well. And we mentioned that. And for women who did get their flu vaccine before they became pregnant, revaccination is recommended during pregnancy to maximise pregnancy protection to both mother and child in the first 6 months of life. And finally, on the flu picture, eligibility for flu vaccine under the National Immunisation Program. It's recommended and funded for all children, again, from age 6 months to under 5 years of age, and all adults over 65 years, as well as to all Indigenous people in the country, all pregnant women, and people with certain medical conditions defined in this table, which is on the last page of that Atari handout. And these are the medical conditions associated with an increased risk of flu disease complications and for which individuals are eligible for the funded NIP program. And it identifies those medical conditions that are included for funded vaccine rather than, for example, controlled hypertension, which is not indicating for a funded vaccine, and mild to moderate asthma is not indicated for a funded vaccine, and certain neurological and immunocompromised conditions So that's our indications for National Immunisation Program, which would bring us to the end of the flu component, except that we've got 2 new flu vaccines that aren't funded, and that is flu Cell Vacs and Fluzone High Dose. So let's just examine how that impacts our flu delivery, which complicates flu vaccines, so that even though Medicare rebate uses simple, straightforward level A, example being a flu vaccination, believe it or not, that's the definition example given by the MBS. I don't believe flu vaccination is simple and straightforward anymore. And let's delve into the complexities of it when we consider these new developments in flu vaccines. So the high-dose quadrivalent vaccine that is available on the private market at a cost of around $50 for people, particularly aged 60 and 64, would have a special indication where their immunity may be lowering. They're not over 65, so they're not considered eligible for the funded FluAd quad program, but they may wish to take the choice and have a higher level of protection than a standard dose vaccine at a cost, because it's not funded under the program. Then we have the flu Cell Vac Squad, which we just said has expanded indication and licensing from 2 years of age, and that provides a potential benefit. And the flu Cell Vac Squad is cell-based in its development. To just try and explain this as simply as possible in just a couple of slides, traditional flu vaccines have the virus growing in eggs. Now, it's a mammalian virus. Having to grow in eggs causes it to undergo some adaptation. So the virus actually changes slightly in the development. There's also millions of eggs needed for the development and a lot of time, 3 to 6 months to develop the traditional egg-based flu vaccines. The process, just to show how it's done, is that instead of the virus growing in the egg for harvesting to produce the vaccine, these cell-based viruses are in a cell medium that over generations produces the environment for the virus to multiply, and it doesn't need as long, it doesn't need eggs. It's a perpetual, eternal culture that's growing originally from canine kidney cells. No canine kidney cells remain in it. That was from the 1960s, but the lineage and the medium is what propagates. And so the potential benefit from all this, besides needing no eggs to produce and quicker time period to scale, is that when we look at the genetic scattergun chart, we see that with a cell-based vaccine, the variation from the original intended design of what strains we're aiming for is much closer matched when the time comes when the virus is circulating, compared with a bit of a drifting that has been observed when the traditional egg-based strains have undergone that egg adaptation. It's only a potential benefit. It's only a potential benefit each year, because we don't know how much that matters or how much the virus strains. So it's a potential benefit. We can't even guarantee in any year that there's going to be any benefit over between cell-based and egg-based. But that potential benefit is there, and so that antigenic match may prove to be something worthwhile considering for getting the best vaccine, the best vaccine performance, and the improved efficiencies in manufacturing. But it also comes at a cost, and it costs about double, 2 to 3 times what traditional egg-based vaccines. And that may be of value to people, and that's part of the discussion we need to have. So when we look at our influenza vaccine program, the National Influenza Program is what we focused on, but we need to keep our eye, not everybody gets a funded vaccine, that Fluzone high dose is an option for people to consider age 60 plus, and particularly relevant for healthy adults aged 60 to 64, or even not so healthy adults, anybody aged 60 to 64, who may prefer to have the extra high dose of preparation at the increased cost. And of course, anybody aged 2 and above, it may consider, I mean, I don't think many people aged between 2 and 5 would choose this over the funded vaccine, but maybe they should be informed, and people aged 5 and above up to 64 may wish to consider it. How do we fit that into a simple, straightforward consultation is a challenge to us. And as many conundrums in immunisation delivery, I think this sums up perfectly. If we choose to discuss in detail all of those options, it would be impossible to deliver an efficient flu clinic. Yet if we fail to deliver, to mention and inform people about that, then have we satisfied true informed consent about what their options are? And in many cases, we have vaccines that are very costly, where the National Immunisation Program doesn't cover it, and we have to challenge that role we have of informing people of what their options are, both in terms of effectiveness of vaccine, safety of vaccine, and cost of vaccine. And it's for the individual to make that decision. Our role is to make them aware of their choices. So that's what I wanted to present on the flu program for this year. And then we've got a couple of lesser topics to discuss, equally important, but lesser in time. Bianca, did you want to ask a question there?
Yeah, there was just a couple that have come through related to flu, and a couple that we'll get to at the end. First one relating to flu vax. What are your thoughts on a second dose for those patients who get the flu vax in March, say at the end of June or July?
Yep, so the indication for a second dose is extremely limited to people with, as defined in the Australian Immunisation Handbook. And that's, I think, for people following stem cell transplant. And so generally not indicated, not recommended. I don't think it would cause harm, but it's not currently recommended that it be done.
Yeah, great, thank you. And just a second question, one of the slides talked about severe asthma as being an indication. What's the definition of severe asthma in relation to that?
Yep, so we really have to look into the handbook to get assistance with that. And it's generally defined that for asthma, people who have either required hospitalisation or have had emergency presentations or on multiple medications for asthma. So if a person is on multi-dose on regular steroids and inhaled steroids, and who have requirement periodically for oral steroids, then they would definitely be a yes. But if a person has episodic asthma controlled with simple short or longer acting beta agonists, then they would be considered mild or moderate and not eligible for a funded vaccine program under the current definition of the National Immunisation Program.
Great. And there's a question around how likely a pharmacy going to stock Fluzone HD and, sorry, forgive my pronunciation, Fluexlavax quad, given that it's not funded. And what if we recommend these for patients, but they are having trouble buying the vaccine?
Yep. So for Fluzone HD and Flu Cell Vac Squad, they would either require a prescription, and the pharmacist would get them in their normal ways, or for practice to stock it themselves and supply it at point of care. The options there for either, but it's not available. So neither of them are available on the National Immunisation Program, and they would have to be ordered specially or scripts written.
Great. And just one other question related to that. So the side effect profile of Flucevax and high dose Fluzone compared to other vaccines.
Yep. So marginal increase in local reactions and common systemic reactions, but not of significance, but slightly increased in reflecting the higher adjuvanted in the fluad quad and the quadruple dose in the HD Fluzone.
Great, thank you.
So thanks, Bianca. Let's now look at pneumococcal vaccination and why is that important to flu? Why are we talking about pneumococcal vaccination in a flu update? And that's because the two go hand in hand. And there were significant changes introduced early in the pandemic year on the 1st of July 2020 affecting adult immunization program for pneumococcal, and pneumococcal is a important factor. I think in the Spanish flu pandemic that killed 50 to 100 million people in a year. Most of those deaths were actually from secondary pneumococcal infection. Pneumococcal is a year-round disease, and pneumococcal it's got a seasonal peak in winter together with flu, and it's got a lot of similarities and a lot of differences, in the vaccination program. But it's equally important for us to keep our eye on the ball for pneumococcal disease. The program for pneumococcal program is ostensibly to protect against invasive pneumococcal disease, including meningitis, septicemia, and bronchopneumonia. But it's also important for focal pneumococcal disease protection for otitis media and for focal pneumonia, so eye on the ball for pneumococcal, given that those changes in 2020 were to attempt to align the extraordinarily complex pneumococcal recommendations that existed before, and to try and bring them up to date with the evolving picture of pneumococcal epidemiology that was evolving because of vaccination for children changing the picture of what pneumococcal strains circulate. And it is an evolving and a dynamic picture to try and keep up to date with. So things are changing and the program needed to be updated, really talking about the Prevnar 13 childhood vaccine being considered of great value to adults and elderly people. So the introduction of that was to keep up to date with the clinical changes and also to try and simplify what was a total dog's breakfast in adult pneumococcal vaccination for all of us who are trying to decipher the recommendations. But no changes to the routine infant childhood schedule for the Prevnar vaccine. So you'll remember in July 2020, in the month preceding that, we received on our desk a package of guides and schedules, and everybody recognised the complexity in the government recommendations and the Atari supportive documents. That was about there are dozens of pages involved. So NCIRS, Immunisation Coalition, Melbourne Vaccination Education Centre all recognised a need to help clarify the clarifications. And so we're going to try and dissect that out and present in 10 minutes a guide so that you can implement it as effectively as possible. The program does unfortunately go only part way in helping to make it an easier program than existed before July 2020. So there's revised eligibility for the National Immunisation Program funded pneumococcal vaccines versus the non-funded. So we have a critical distinction between what is now recommended for people to be vaccinated and the subgroup of them for people who are funded. And certain medical conditions that were funded for assistance in purchasing vaccines have changed and been to disadvantage people. So let's look at that, including the removal of the PBS listing for Pneumavax 23. The 23-valent pneumococcal polysaccharide vaccine is no longer on the PBS where it was prior to this change, and there's impact, which we'll look at. So to dissect out the groups of adults who were formerly eligible for a PBS script for Pneumavax 23 are now no longer eligible for an NIP-funded vaccine, even though they're recommended to have it. These include all smokers, all people with diabetes, all people with asthma of all severities, and COPD, non-suppurative chronic lung disease, and interstitial fibrotic lung disease, who were all eligible for a PBS script prior to July 2020, no longer eligible, all recommended to have pneumococcal vaccination, all not funded. And the list goes on. In people on immunosuppressive therapy and non-hematological malignancies, whether they're receiving chemoradiotherapy or not, cardiac, liver, or renal disease, unless their renal disease is so severe that their eGFR is under 15, that's stage 4 to 5, also known as end-stage renal failure. So the exceptions that are better off under the program are for age-eligible National Immunisation Program funded Prevnar for non-Indigenous adults and for Indigenous adults over 50 years of age. So we have to dive into this chart to understand this is what you need on your desk or on your wall, and best to refer to this to get the answer of identifying the doses and the scheduling for the different cohorts and whether they are funded, recommended to have the funded program, recommended to have a pneumococcal vaccination or funded or not. So we'll dissect it. These are the 5 columns of indications and what is indicated and when and at what interval. So the green here, as opposed to the purple, the green is the 13-valent pneumococcal conjugate vaccine Prevnar 13, and the purple is the 23-valent pneumococcal polysaccharide vaccine Pneumavax 23. And you can see that the universal childhood schedule has at age 2, 4, and then at 12 months, and that didn't change in July 2020. All at-risk children under 12 months of age with a risk condition that we'll look at on the flip side of the page in a moment. So if they're on the flip side of the page, or they're Indigenous children under 12 months of age living in Northern Territory, Queensland, South Australia, or WA, they're recommended to have an extra Prevnar at 6 months, as well as extra Pneumavax vaccines at age 4 years and then 5 years after that. All children, adolescents, and adults over 12 months of age diagnosed with the risk condition on the back of the page are recommended to have their 13-valent Prevnar vaccine at the time of diagnosis or recognition that they're due to have the vaccine. If they might have had diagnosis 10 years ago, but no one realised they are indicated to have it until now. So to give it as soon as possible that it's recognised or indicated, plus 2 doses of the Pneumovax at those time intervals mentioned in there. All Indigenous adults without any risk condition at age 50 are eligible for a funded Prevnar 13 vaccine, followed by 2 Pneumovax 23s at those periods. And all non-Indigenous adults without a risk condition are listed on the back of this page that we'll look at in a moment. They're all indicated to have a funded Prevnar 13 vaccine at age 70 years, regardless of whether they got a Pneumovax vaccine funded when they turned 65 or in between those times. So this is the new 65, and the Pneumovax is now Prevnar for non-Indigenous adults, age 70 above, 1 dose. So now we zoom in on the flip side of the page to have a look at whether the condition is listed here. Having a listing here means they are recommended to have pneumococcal vaccination according to that decision tree that we saw. So if they're on this page, we apply this. However, do we give it to them free or not? And here is the eligibility column, which has a tick if it's funded and no tick if they're not funded. And this is the column for age under 5 years, and this is the column for 5 years and above. And there's an asterisk there around renal failure, because we just mentioned that a minute ago, of the stage of renal failure that gets the tick. And if it's less than that, no tick. And you'll see the conditions that I identified before. For adults, these conditions are recommended to have 3 doses of pneumococcal vaccine at no funding and no PBS listing. So the impact of this is what was expected and was valued was that an improved protection from the addition of the 13-valent pneumococcal for the elderly people, small and high-risk people, a small delay of routine pneumococcal vaccine protection to shift from the commencement of their protection that was age 65 to age 70 is a bit of a disadvantage for those people, but the experts decided that was justified. The National Immunisation Program is not a cost burden for healthy Indigenous people over 50, healthy non-Indigenous over 70, and for those specific cohorts who are the highest at-risk condition. So the people who need it the most are eligible at no cost, whereas prior to the 1st of July 2020, the cost to them on the PBS was $21 for the 3 pneumococcal vaccines they were recommended to have and available on the subsidised PBS, but they did have to pay $180, even the highest risk group, if they were indicated to have a 13-valent. So the change that occurred is that those people are advantaged, and that's great. But the unexpected impact is that the burden for vaccine providers for us to try and get our minds around all this means that complexity is still a very significant barrier to implementing it. And the NIP recommendations, I believe, are not any simpler, nor are they easier to understand than existed before. It might not be a dog's breakfast anymore, but it's not much different from a dog's dinner. The removal of PBS listing for the 23-valent Pneumovax 23, I think, has compounded this disadvantage, not for the people at highest risk, but for the people, most of the people who are at risk. So the majority of people who are on the at-risk list don't qualify for the highest at-risk risk. And so those people are needing to fund their recommended vaccination program at a cost out of pocket of $300, comprised of a 1 dose of the Prevnar 13 at around $180 and 2 doses around $65 of the Pneumavax 23, no PBS listing. And that includes all of those groups I highlighted, whereas previously they were able to cover themselves for the recommended doses, albeit without the Prevnar 13, or for either $14 or $21, depending on what they were recommended to have at the time. So I know this is complicated. The Immunisation Coalition have produced a NumaSmart vaccination tool for which I was a contributor. And it, by clicking a few details, can help sort out where the person in front of you is on that chart, and can spew out for them by putting in a few details like their age, their smoking history, their indigeneity, and their medical conditions, and whether they've had vaccines in the past. And you get a handy report at the click of a button, which when you expand the summary tells you what vaccines to give when, what next vaccines to give, and whether it is funded or not. So that's a very handy practical tool called NumoSmart, and you can Google that. So to conclude this section, just to clarify what I believe the implications are for at-risk individuals and vaccine providers in the community. For the individuals, I think that people remain underprotected or significantly out of pocket in providing what's recommended for them, and that there is a special neglected cohort of those with multiple at-risk conditions that don't qualify for a funded vaccine, and they miss out. All these people miss out because it's too complicated for us to take the time to explain it to them in an otherwise busy consultation. And so we're expected to implement this. Nobody else is aware. The vaccine providers are expected to implement. Nobody else is aware of the complexity and the need. We're confused and overwhelmed and unable to implement it effectively because we're, for goodness sake, COVID burned out, let alone everything else. And we were in this position even before COVID, where pneumococcal vaccination was so complicated. And so it's just another element to contribute to our emotional exhaustion. And the community miss out because of the disappointing low pneumococcal vaccination coverage rates, which I jumped over talking about because of time constraints, but we're only not even half protected in terms of people eligible and recommended to have it. And we are especially neglecting cohorts of at-risk adults who can't afford. And so here we have this same slide, can't afford to have what's recommended by the National Immunisation Program, but not funded. So here we have this slide again. We are really on the horns of the dilemma of how to deliver informed information to help inform a decision for them to fund whether something is worth them paying for. Is that a priority? Remember, cost is only one element in a person deciding what value that is for them. And if we do take the time, then how do we contain consultation into a reasonable time? Big challenge for us. Those tools will help, but that's where I think we sit. Bianca, before we move to RSV, yes. Did you want to ask a question there?
Yeah, there's just a couple. Thanks so much, Peter. The first one, if a child has Prevnar 13 at 12 months, then diagnosed with conditions funded at age 13 months, do we give a repeat of Prevnar 13?
So that's a very good question, and the answer is that the children who've already had, and the same applies for adults, the principle's the same. The recommendations for people with certain conditions are to have those vaccines in their lifetime. So if they've indicated to have a Prevnar or a Pneumovax and they've already had a Prevnar, then they don't need it again unless their schedule changes to suggest it. So no, in general, they've already had their Prevnar unless they've got more on their age, on their recommended age time. But what they've already had counts towards what they need, let's put it that way, both for Prevnar and for Pneumovax.
Great. This seems like a similar question, so you may have answered it. In someone in the at-risk group who has Pneumovax 23 instead of Prevnar 13 when first diagnosed, is it okay to give them Prevnar 13 2 to 12 months later?
Absolutely. And so those time intervals on that decision tree chart help guide when to give that. And the answer is absolutely yes. It doesn't matter if they get them out of order. It just makes it a little more complicated for correcting and bringing them up to date at the end of the time period. So you still stick to the time intervals, but you catch them up for whatever they've missed.
Great. Thank you very much.
Terrific. So why are we talking about RSV? Well, before we do, I do want to give credit to Dr. Gemma Saravanos for the production of these slides, which are really excellent and help us understand it. So RSV, really? What is this about? We don't even have a vaccine for it. So why is it in this presentation? So I do want to commence by declaring that I'm an investigator for an RSV vaccine study, and I have been for the last 3 years. And we are getting close, I believe, to having RSV vaccination introduced in the future. How much time, whether it's 2, 5, 10 years, we can't tell, but I do think we need to raise awareness so that when a vaccine becomes available, we have a receptive audience who understands its role. And so right now, I want us just to get our minds around what RSV is doing and what why we have a need for an RSV vaccine and why so much investment is going on and why it's failed in the past and now it's looking to be more successful. So with that background, I want to emphasize that respiratory syncytial virus is leading cause of acute lower respiratory infection in three particularly important groups: young infants and extreme old age and people with immunocompromised and other risk comorbidities. There is no licensed vaccine at the moment. There is limited treatment. There is available palivizumab as a monoclonal antibody immunoprophylaxis, but only people in intensive care and severe cases can access that, and it's an extremely expensive medication. So to all intents and purposes, there is no effective treatment other than supportive treatment. The spectrum of disease severity is significant and affects very high incidence of children around the world, both in mortality and hospitalisation, and adults in extreme age, and a high number of emergency department presentations with bronchiolitis and also community illness of mild degree being the predominant. We probably all get several RSV infections in any year, some of which may be asymptomatic, some mild disease, but severe disease and pneumonia in very elderly people. In the UK, they say that the burden of RSV in children exceeds that of influenza. And that is now what the Children's Hospital in Melbourne have said for a couple of years now, that with universal childhood flu vaccination, the RSV incidence for hospitalisation to Children's Hospital in Melbourne is now exceeding, mirroring that pattern in the UK. So the disease in young children is significant, and the age of the child for the severity of the disease. So we're looking here at hospital admissions per 100,000 population, with the 0 to 2 months being in this band. And older children, as your age matures, your risk of hospitalisation reduces. But this is a very significant number. And hospitalisations in Australia have caused a very high number of cases, and a scary disease with croup and bronchiolitis in young children. The disease can be very distressing. Child deaths are significant and particularly so in lower and middle income areas where the disease burden is greater. So this is saying that the risk of mortality, you need to have high number of comorbidities to have an impact on mortality, but in lower socioeconomic countries and areas, the majority of people without medical comorbidities. And in New South Wales, the data over a 20-year period have shown a population death rate of 1.2 per million, and that's quite a significant number. So RSV is associated with substantial disease burden in adults compared to flu, with most of the hospitalisation and mortality burden in the elderly. And the disease in elderly, this shows you the hospitalisation admission per 100,000 for people over the age of 65. And this is of great significance in terms of numbers of people getting pneumonia requiring hospitalisation, increased death, severe outcomes and death, and associated diagnosis being a high proportion of those people. So the development of a safe, effective and affordable RSV prevention is now a global priority. And for 20 years, RSV has evaded vaccine production. They've just failed. They've technical reasons I won't go into because of time at the moment, but they now look like they're breaking that and getting the technical vaccine to produce effective protection. And so there are studies now reaching mature levels for pediatric studies, maternal, which provide protection to the mother to help protect the baby in the first 6 months of life, and also for elderly that are targeting these particular F fusion proteins on the surface of the RSV virus. So large numbers of studies reaching quite mature level of phase of development. And this is the study that I'm involved with up here, and other studies looking at the different ages are also reaching maturity and reporting impressive results. But the awareness of respiratory syncytial virus as a global health problem is very lacking. And that is that people have heard of bronchiolitis, they've heard of croup, have heard of pneumonia, but they haven't heard of RSV. And even of pregnant women, 83% had not heard of RSV as an entity. So familiar to us in healthcare, but not so familiar in the community. So we've got Buckley's chance of rolling out a vaccine when it does become available if people have never even heard of it. So understanding RSV activities key for planning health service delivery and timing of interventions. Normally, there's a very distinct seasonality with coinciding with flu season, and a lot of disease that we see that we call flu-like may even be RSV, and the timing of it was closely linked. Not so during the disruption of COVID, which has thrown the pattern of RSV illness a bit askew, but whether that returns to, but other significant thing is it was one of those respiratory viruses we talked about earlier that did not go away like flu did during COVID. It just shifted in its pattern a bit and may do a bit of a jiggle, but still significant numbers of cases, even with all the isolation and the masks and the preventive measures. So lots of movement on surveillance. It's not yet a notifiable disease in all of Australia. For example, Victoria, it's not, but some other parts it is, and it will become RSV notifiable, it's predicted, in the next short while. And the RSV development for vaccines for different risk groups is now really highly developed and close to maturity. So I mentioned I'm an investigator, and we're opening recruitment shortly for people aged 65 and over for a RSV vaccine being given at the same time as flu vaccine. And if you have patients who may be suitable for our study, we will return them to your regular care after just 3 visits. And of course, in between those 3 visits, they'll be seeing you, not us. But if that's of value or interest to you in the area, please feel free to refer anybody to our clinic, and to me in particular as the principal investigator, and quite happy to discuss with you offline if you want to contact me to discuss that. Finally, for tonight, I just want to touch on the rest of the Vac safety a program to show its relevance to the other vaccines on the National Immunisation Program other than COVID and flu, and to demonstrate the range and depth of the data available. We looked at COVID, we looked at that data, those slides. We looked at flu and the flu. So I want to now move to the others to explain that. Just how it works is a number of participating practices, hospitals and clinics, general practice, the majority, but also many other participating hospitals that contribute a free text message service that everybody attending a vaccine at that participating site will be sent, and they'll get it 3 days later as a text message asking them if they had any reaction. And if no, they simply tick no, and that data helps contribute to the no reaction data. If they tick yes, then a follow-up survey simply asks them in that next text message, how bad was it? Did you need to see a doctor or attend an emergency department? And if they answer yes or no, that contributes to the severity data. And then a couple of very quick questions about what sort of symptoms and how long did they last. And so with that process, we've seen a growing of the number of sites participating in the Vac safety program, mainly through Smart Vacs, and we see a very high response rate of around 70% on average for all people who receive a vaccine of actually responding and providing valuable data. And across all vaccines and all ages, about 80% of respondents report no adverse reaction whatsoever. The types and frequencies of vaccines are as expected in clinical trials as a general comment, and most adverse effects are mild and go away within a few days. And this system also helps pick up safety signals of unusual reactions that occur. And the whole program was stimulated by a friend of mine, GP in Perth, Dr. Alan Lieb, who, following the WA experience with 2010 seasonal flu vaccine reaction with Fluvax that occurred at the time, put into motion this program to be an aid on the desk daily to help signal any rare reactions that occur like that. So just to show you before I finish the types of charts that are updated weekly on the Vac safety program to demonstrate, say, for routine childhood vaccination at 2, 4, and 6 months of age, your chart helps identify those who had no reaction, those who had any reaction, those who had reactions severe enough to need medical attention, the types of reaction and their proportion for each of the age against the particular vaccines that they were given at the 2-month schedule, the 4-month schedule, and the 6-month schedule. Furthermore, the 12-month age, 18 months and 4 years of age for the other age child children, all demonstrate in a similar pattern to be able to explain, as well as adolescents for Gardasil HPV vaccine and DTP booster, as well as the 14 to 16-year-old meningococcal ACYW. Pregnant women displayed against both the DTP booster and the seasonal flu vaccine that they are recommended to have during pregnancy. And finally, the older adults, that is people aged 65 and over to get their, 70 years and over for their Prevnar 13 and their Soster Vacs, and the reaction proportion, as well as all those seasonal flu ones that we saw broken down for all the different ages. So with that, Bianca, I think we'll move to some questions, but I'll thank everybody for your attention. If I had to summarize all of this in one picture, that's my favorite picture. That, I think, summarizes flu vaccination and all of us having to try and manage it. Thanks.
Thanks so much, Peter. I can certainly relate to that that picture you put up there. Kathy from Eastern Melbourne PHN is going to kick us off with a couple of questions that have come through.
Sure. A couple of questions in the chat area. Patient is going overseas to Vietnam. She is asking for family immunisation with Japanese encephalitis vaccine for adult and the kids under 3-year-old. The mum is pregnant at 10 weeks.
Absolutely. So 2 answers to that. Firstly, if I can take the liberty to modify the question, that could equally apply to many people moving to northern Victoria because of the Japanese encephalitis virus, unprecedented appearance. Not many cases, but enough to be worrying. And so preventative measures for those people are like DEET containing repellent is what's appropriate for most people, but certain people will be indicated to have Japanese encephalitis vaccination if they are particularly working with pigs because of the water around the pigs and pigs being a vector. So the pigs don't cause the Japanese encephalitis infection, but the mosquitoes that breed do. But specifically for that question, that travel specific question isn't just a simple answer. So I'll refer you to get the entire answer from the Australian Immunisation Handbook, Japanese encephalitis, and it will give the different recommendations and options for live and non-live vaccine for different age indications. So there's a beautiful chart on the Japanese encephalitis chapter. It's not a long chapter, but it gives the practical answer to what you said, and there's lots of different answers for the different ages. In a word, there's Japanese encephalitis vaccine called Jespect, and there's also Japanese encephalitis vaccine called Imajev. Imajev is a live one. It's got different age indications. It's got different advantages and disadvantages. Costs for Japanese encephalitis vaccination is expensive, around $300 per person to get protected either with 2 of the non-live Jespect or 1 of the Imajevs. And the future doses is different. So both in terms of what vaccine is given, generally Imajev is not recommended necessarily for future booster, but Jespect is a 2-dose schedule and does require booster doses. So I'll refer you to the Australian Immunisation Handbook chapter for that.
Thanks, Peter. Another question. Have you noted the elderly getting more GI upset reported as an adverse reaction post-immunisation?
From which vaccine?
Not specified. I wonder whether it might have been the COVID vaccine, though. It came up at that time.
Yep. So I think if we go backwards to that slide, so the short answer is I think it's yes. We'd have to have a look at the detail of that, and I don't think I can jump back to it just at the moment, but that data will include that in the fine. I think one of the charts but the answer is yes, some increased incidence, but it's also a symptom of COVID infection, if that was the context of the question. Yeah.
Peter, I'll go to one around Hep B, actually. So I see many 18 and 19-year-olds who have low immunity to Hep B after having the primary cause of Hep B as a baby/child. I administer a paediatric dose of Hep B as a booster as they are under 20 years of age, but others administer an adult dose, which is correct and is either okay.
Yeah. So the hepatitis B chapter in the handbook does discuss the different interpretations for vaccination of or approach to people who've had vaccination and then subsequently have low levels of antibodies apparent on serology. So it isn't a straightforward answer because it does depend, like many of these things. So in principle, hepatitis B vaccination produces an antibody response that can appear to fall in the serology measure, but can have a rapid memory response after exposure either to a subsequent vaccine or to hepatitis B virus. So the general recommendation is that if a person has had a complete course of hepatitis B vaccine appropriate for their age, which might be a 3-dose schedule or it might be a 2-dose if they're adolescents between the ages of 11 to 15. But if they have subsequently returned a serology level that is protective and then later it falls, that doesn't matter. They're considered protected and don't need to have booster. But if, like the example you gave for the person that asked the question, you've given pediatric or adolescent doses and you don't know what their level is until someone tests it and finds it's low, you can't make that assumption. So you do need to give a booster for an adolescent or adult where the level has fallen, but then you should repeat their level and see if it's come over the protective defined level, and if they're seroprotected, then they don't need any further boosters. But if they don't come over that level and they haven't completed the then they may need extra boosters, either as double doses or extra course of them. So, tricky answer. The question also, you need to have a look in the handbook because it's multifaceted. I should have said that at the beginning and saved all the time of the description.
Peter, next question. What happens if someone received Pneumavax 23 over 65 years old prior to July 2020, then they turn 70? Do they get a Prevnar 13 dose?
They do, and it's funded. And they'll have extra protection beyond what the standard recommendation is for people who didn't have a 65 Pneumavax. So short answer is that yes, they get a funded Prevnar 13 at age 70, and that will complement and supplement the Pneumavax vaccine they had earlier. But if they didn't get a Pneumavax earlier for whatever reason, then they don't get another one. Yeah.
Thanks, Peter. We've got about 3 minutes left and 3 questions. So put you under pressure. Can Novavax be given to pregnant women either as a primary course or as a booster?
Can Novavax?
Novavax.
So I don't believe it's, we'll have to check the last 3 minutes. I think my mind's numb, but an mRNA vaccine is preferred for pregnant women. I'm sorry, I'll have to defer to the, actually, we can use these charts. If I jump in here, I should know the answer, but just to have a look in the fine print there, it'll go over the 3 minutes, but it is there.
That's fine, no.
Have a look. Sorry for that, I think not. Go ahead. What was the next one?
Next one is, are practices still able to register to participate in the AusVax study?
So it's an ongoing AusVax program rather than a study. and you would access it if you're a vaccine clinic via SmartVax. So if you reach out to SmartVax, who have representatives in all states, they may be able to advise whether you can join us simply as you should, but yes, in principle, via SmartVax.
So another question re COVID vaccination. What do you say to a patient who has had 3 shots, but her COVID antibody test came back as not detected?
I'd say, why did you do a COVID antibody test? The value and meaningfulness of a COVID antibody test is limited to very, very rare occasions. We don't have a level of protection. There is no reference, so we don't know what's protected, what a level means. If you do an antibody test and you get a level of 5 or 50 or 50,000, it's not a level. It's not a correlate for protection. So you don't get the answer from that test. All it can really tell you is whether the person has had either prior exposure or prior vaccination. And it doesn't tell you whether they're protected or how long for. It will provide better information when we have available antibody tests that distinguish between the being infected or being infected or having vaccine protection. So they're coming. They're not here yet, but we expect that will be of value. And in the meantime, I think you're looking for a level of meaningfulness that test doesn't provide yet.
I'll ask the last 2 questions as one, Peter. Can Prevnar 13 and Soster Vax be given at the same time? And if so, would it cause more side effects or adverse reactions?
So I believe there is a caution that there may be increased reactions, and if that's a concern, then whilst they're not contraindicated to be given together, they recommended that it may be worth separating by a few days. But I would normally answer that question with the handbook in front of me. I'm not having doing that off the top of my head. I apologise that I'll refer you to there at this time of night. Thanks.
Thanks, Peter.
Definitely a good plug for the handbook, Peter. So thank you so much, all of you, for joining us tonight. Peter, you might not be able to see, but there's lots of commentary in the chat about thanking you for such an informative presentation. So certainly on behalf of West Vic PHN, Eastern Melbourne PHN and Northwest Melbourne PHN, go remember where I'm from. Thank you so much for taking up your time, and thank you for everyone for giving up 2 hours, a really worthwhile session though, and a huge amount of information that you were able to impart in an easy to understand way. So really appreciate Peter, you taking the time, for PHN colleagues for being involved, and all of you for attending. I hope you've enjoyed the session. There will be an evaluation survey that is sent out, so it'd be great if you could fill that out as well and gives us some really good feedback for ongoing sessions. So I'll let you head off into the night. Thank you all for coming along.
Thank you.